Often we are asked which drug may make the best quality embryos and which drug would give you the best chance of pregnancy. So this was a study which was recently published on oocyte competency and is it affected by gonadotropin choice? And what you're looking at mature eggs, you're looking at blastocysts, you're looking at genetically normal euploid embryos. If you have a look at this paper, it was again women who were more than 35 years were selected in the first IVF cycle. So the drug choice was recombinant FSH on its own, recombinant FSH plus LH, recombinant FSH plus HMG or HMG. I looked at euploid blastocysts and metaphase 2 oocytes. And so what they found was that there was no significant difference in euploid blastocyst rate. Live birth rates were very comparable. Maternal age was the most important factor that affected the outcome. And oocyte competence, that's egg competence, was unaffected by gonadotropin choice. So the overall, the focus should be, when you have a look at it, the focus has to be between assessment. So whenever you plan to treat and stimulate, you look at the age, ovarian reserve, and response history. Choose the gonadotropins based on those goals. So, and optimize the dose. What you don't want is to overstimulate or understimulate, and focus on follicle count rather than oocyte quality. So see how many follicles get recruited. That's key. So right from your baseline follicles to what is recruited, an egg to follicle ratio then matters. So there's two parameters which it's very important you have a think about. So what are the limitations of this study? Small size. And so if you have a study with small size, it has more bias. A retrospective design. So again, it lends to bias and there's no randomization. And these results may not apply to younger women. It may not apply to women with PCOS or severe male factor. So we think that the study was done in women over the age of 35. When you compare them with previous studies, current study said there was no effect of gonadotropins. There have been studies that looked at animal studies and they've looked at giving higher dose of gonadotropins may be helpful in few cases. But what this study tells us is that increasing the gonadotropin dose does not lead to more abnormal embryos too. At the end, there's still scope to do a lot of research in this, looking at mainly randomized controlled trials, looking at mosaicism and changing the population. So if we look at the clinical implications, the one is look at the age. That's where you can be flexible with protocols. Ovarian reserve, your dosing should vary, and expected response again will influence protocol, and infertility cause again may affect strategy. For all these, what affects oocyte quality? It's age and maybe to some extent an infertility cause. So what is the key point from this study? That no significant difference whichever gonadotropin you use. It does not have an impact on euploid status, on metaphase 2 oocytes, comparable live birth rates, and dosage differences may have an effect. We know that recombinant FSH is much stronger. It gives a shorter stimulation and has a lower FSH dose compared to HMG protocols. But this study suggested that it does not significantly affect the oocyte competence in women over the age of 35, where age again tends to matter significantly. Thank you.